Bon dia for those in Brazil. Good morgen for those in Germany. Hello to Ashley as well. It's very good to be able to give you a short slide presentation on quality assurance in urodynamic studies. I hope that my background as a clinical engineer will be helpful in presenting measurement techniques and good practice in urodynamics. Firstly, I'd like to start by talking about quality assurance. What is this? Why do we try to achieve it? Quality, the first word, means what you see is true. It means that if you're accurately recording something and displaying it, then you've got a true value, a good quality value. Assurance, however, is something extra. It means that you know that it's true. You've got some reason behind your trust in the figure that is being shown. But if you don't have that assurance, if you can't trust it, then you change the reading, and that's where quality control comes in. So what we're aiming at in urodynamics is to have assurance of quality. We have a good reading and we know that it's good. Now, in the International Continence Society, there have been developed guidelines for what is good enough quality for clinical use. You don't have to be absolutely perfect, and of course life is not anyway. But what in your flow rates you can say is that between 1 milliliter per second, either side of the true value, is acceptable, good enough accuracy for clinical use. For pressure, on the bottom line, we say that 3% is a good enough accuracy for pressure values, or if the values are really small, 1 centimeter of water accuracy. You don't need, therefore, to present your pressure values to 0.1 of a centimeter of water. That is not clinically useful. You can find those levels of quality, those guidelines for accuracy, in this paper quoted. How do you know that you are within those levels of accuracy? Well, what is advised is that you regularly verify your calibration. With your flow meter, or indeed with your fluid bag for infusion, it's quite easy to do. You can see the volume on the side of a jug. And if the volume on the side of the jug is 142 milliliters, you want to just check that your machine is reading that value, or near enough that value, within 5%. For pressure, it's very easy with a water-filled system to check by raising the fluid line and seeing that the pressure rises by the amount that you've raised the level of the fluid. These two are very quick checks to do. You don't need fancy equipment. All you do is use the equipment as it is set up to quickly check you're within calibration accuracy. So how do you gain assurance during a study? Well, the tricky area normally in urodynamics is between the patient and the transducer. And the three main checks, once we've calibrated our equipment, are to check the resting pressures within the patient, to check there is a live signal, little movements on the pressure due to breathing or talking, and to get the patient to cough regularly. Once you've got the signal on your system, then you need to make sure that you understand the display as well. And that means getting rid of the unwanted signals. So when a patient moves, for instance, they knock the line and you get a pressure rise. That is a real signal. Your transducer is telling the truth. But you're not really interested in that clinically. So you have to learn to see around those artifacts to gain your assurance. So let's look first at those first three, the patient to transducer signals. I'm sure that you'll be aware of the normal resting pressures that have been ascertained through a long experience of urodynamics and are listed in the Good Urodynamic Practices documents of the International Continence Society. When your patient is supine, seated or standing, you would expect the vesical and the abdominal pressures to be within the ranges stated here. That implies, of course, that your water-filled transducers are set at the level of the symphysis pubis bone, which is the standard reference height. And that means that if everything's set up correctly, your pDET should be within a few centimeters of water of 0. You also should be able to see on your picture a live signal and the cough tests, like the image here. You should be able to just make out that on the red and the blue lines, that is the abdominal and vesical pressures, there are movements as the patient breathes and talks through the study. And those are largely subtracted out on the green detrusor line here. The cough pressures too, the lines go up equal amounts and you get these small biphasic spikes up and down, telling you, because they're equal heights, that the signal is being processed well. So once your resting pressure, your live signal, your cough tests are all within these ranges, and you know that your equipment is calibrated, you can have assurance that you're picking up real, correct pressures from your patient. Now, once you get artifacts involved, you're going to need to have a bit more experience and background to this. And there's good guidance in the Good Urodynamic Practices document. The new one from 2016, and this reference here of 2017 is the exact journal reference, has got a long list of different types of artifacts and different types of terms. It takes these from a paper slightly earlier that uses this diagram to split out the different causes of artifacts and the different useful features. So these terms here will be helpful if you can get to understand them using the Good Urodynamic Practices document. And if you find that you've got staff you want to train, you can use this teaching module from the ICS that gives a slide set and the same terminology as in the Good Urodynamic Practice for artifacts. So all these tools will be able to help you to screen out the true signal from any artifacts present. I'll just have a look briefly at a couple of common artifacts. Here is a cough response. The first one at point A shows that the signals are slightly different on the blue and the red lines. And you can confirm that by this negative spike on the pDET line, the green one. The red arrow shows you where this line has been flushed to get rid of an air bubble, perhaps, that was there. And the next cough at B gives equal height lines, no change on the pDET line, the green one. So you can be assured now that the air bubble is out of the way and that both lines are reading pressure equally well. So that's something that you would do interactively during the test. Get the patient to cough. If you see unequal heights of cough response, then you would flush and check again. The other thing that I'd like to highlight in terms of good practice is zeroing to atmospheric pressure. This is what you would do at the start of the study with your transducers exposed to air only, not the patient. The benefits of doing this are many. Firstly, it's standard practice. But secondly, those resting pressures that we looked at earlier are only valid with respect to atmosphere. That's how they've been determined. So if your reference point is anything other than atmosphere, you will not be able to have a check of your resting pressures. The other benefit of zeroing to atmosphere is that you're recording the true pressure inside the patient. If you start off your study at the pressure within the patient, which you don't actually know, just calling it 0 will mean that you're only measuring changes in pressure from the starting point. You're not recording the actual pressure inside the patient. The other problem if you do that is that you might be zeroing on the top of a detrusor overactive wave, or maybe some rectal activity. It means that the 0 in the patient is not properly 0 at all. If you do it to atmosphere, however, you've got a static, stable, and known value as your reference. And also, during the test, if any signal reduces and you've started at 0, then of course it will go negative, and no patient has within them negative pressures. So here's a picture of someone who has zeroed out the high abdominal pressure at the beginning and just called whatever pressure it starts at 0. It makes for a nice trace, but what you've done is perhaps got the rectal balloon next to some compacted feces or the anal verge. And you've said, well, let's not worry about that high pressure, we'll ignore it and call everything 0 at the start. The problem with that is that if the feces moves out of the way, or the balloon moves away from the anal verge, you get pressure variations recorded that are nothing to do with the bladder. So a good guideline to observe is 0 to atmosphere. So those two, the cough test and the atmosphere, are applicable to any urodynamic test. But let's look at some things that happen with prostatic obstruction in urodynamics. One thing that can happen is that the vesicle catheter gets expelled. There's a reasonably high pressure here on the vesicle line. And what's happened is that the pressure line has fallen out at the point of the red arrow here. The flow of urine, because in this case it's pretty good flow, has pushed out the catheter with the pressure. So the vesicle line goes right down to some negative value. And in fact, you can see on the flow rate that there's been a spike in the flow as the fluid rushes out with that catheter all of a sudden. Now this means that you don't quite know what the maximum flow rate was at the maximum, the P det at the time. What I mean is that the P det has stopped being read by the time the maximum flow has been reached. You can see that it drops before the peak of the flow. Now that means that it's going to be a little difficult to diagnose precisely whether this patient is obstructed or not. As it happens in this case, the flow was so fast that you're very doubtful they're obstructed at all. But I think you can see that if the flow was slower and the catheter fell out, then you wouldn't be quite sure of the diagnosis, because the maximum flow rate point does not have a pressure associated with it. Sometimes you may have to do the test again. This is another thing that can happen with male flows, particularly some sort of artifact. Can you see at point 1 that the machine has automatically registered 33 as the maximum flow? In fact, what has happened is the man has moved his stream over the funnel and given a little spike in the flow, and there's a drop afterwards. So that spike is an artifact, it's not his true maximum flow. Point 2 is perhaps a better estimate of the maximum flow of 19 milliliters per second. So take care that your machine hasn't automatically given you a wrong reading for the maximum flow. The same is true, in fact, for all the other markers during the test. Check that the markers are rightly saying the patient position at the time, the sensation the patient felt, and so on. Because after the test, you won't be able to verify these. Just one last item that may affect some diagnoses in male urodynamics is this artifact where you can see the values of PDET Qmax and Qmax are here 25 and 26 respectively. But look up at the abdominal pressure line. At the point of maximum flow, P-abt is reading 15. But before the flow started, their real P-abt was 23. And what is hypothesized here is that the pelvic floor has relaxed, the local pressure surrounding the rectal probe has dropped by 8 centimeters. That means that your PDET Qmax needs to be dropped by a further 8 centimeters in order to subtract the true pressure around the bladder. Thus, PDET Qmax is really 17 in this case. Now here, it doesn't actually make a difference to the diagnosis, but there are times when this might mean that the patient crosses a threshold. So take care to check that there isn't a substantial drop in the abdominal pressure as the patient voids. They haven't lost weight, they haven't changed their position, so the abdominal pressure shouldn't really be changing. What we've seen is an artifactual drop that needs to be adjusted for. So those are just some examples of what might happen during male urodynamics. In summary, I can simply encourage all urodynamicists to undertake routine calibration checks, to use the transmission checks of coughing, of live signal and resting pressures to make sure you've got good quality assurance, and then to be able to recognize and understand artifacts. Thank you very much for your attention, and my presentation finishes here, so I'll hand back to you, Carlos, for any follow-up you want to do.
Thank you very much, Andrew.